Hit record. Okay, welcome back, everybody. It is November 5th, and you have Teresa again tonight. We have two different lectures. We have seating technology, and then we have mobility technology. I wanted to start off to see if anyone had any questions. We have Heather with us. Her electricity is back and running. So were there any follow-up questions from last week that anybody wanted to ask Heather before we proceed with tonight's topic? Appreciate everyone muting themselves so we can focus. Okay, so if there's no questions for Heather, we'll go ahead and proceed with seating. We'll go ahead and try and get through this and take a break in an hour. I'm going to ask Heather to help me with the hands up in the questions. I tend to get in my mode for this one. So the learning outcomes is identify impairments that cause a person to need seating technology. We're going to talk about the steps in evaluating for seating technology and talk about major characteristics and features of different seating technology. So the challenge is how do we cover this in an hour? Obviously, this is going to be an overview of positioning considerations. We've added a lot of pictures to help explain some of the different positions, but there's lots of resources to help with this in more depth, and we have a couple of those posted along the way through this module. We're going to go over goals of positioning. We're going to talk about a 24-hour approach, and then we're going to talk about seating options. So with goals of positioning, we're going to work our way through each one of these. I think of these as golden nuggets. And so the first one, correct the flexible and accommodate the thick. So if you think about that, you need to know the person's ability level in order to apply this. So when somebody comes into the clinic, it's really good to take note of their position when they come in, because that may be a position of comfort, or that may be a position the caregivers put them in. But to get a full evaluation that we'll talk about in a little bit is you need to do a supine eval and get them out of their equipment. That eval is going to tell you if their body has the ability to sit upright. Therefore, if it's flexible, we want to try and correct anything that we see in sitting. But if it's not flexible, then we're going to end up accommodating that position that we saw. So correcting the flexible and accommodating the fixed is a really important component. We always want to try and keep the skeletal alignment in symmetry. Sometimes there is an individual that may have a little more range on one side than the other, and sometimes I see that with windswept. They may have tight rotation to the left, but overly more rotation to the right, and so that's why they're windswept to the right, because they just have that flexibility. We want to try and keep them symmetrical and aligned. I like the idea of skeletal alignment because you always want to try and keep the spine stacked, and sometimes when you're looking at accommodation, you may risk skeletal alignment, and that's where you have to kind of come halfway. Postural control. I think of postural control being able to not only sit in a static position, but in a dynamic position to allow people to move in and out of different positions, whether it's moving in and out to grab something on the table or to interact with their environment, or whether they need to do a pressure relief. Normalize muscle tone. I look at seating as you want to use it to disinhibit any tonal patterns, or what the next one is the primitive reflexes. So you want to stop any of those reflexes from happening. Normalized tone can also be, you don't want to trigger like an extension control for spasticity, and so you may want to use a tilt instead of recline because you don't want extensor tone. The second to the last one, I love this one, and I think that this talks to you about the postural control. So proximal stability or distal function. If you can get the pelvis and the trunk under control, you're going to have more support with your upper extremity. I tend to always start with the pelvis, trunk, then I'll work my way down to the legs, and then the last part is I'll look up to the upper. Somebody that might have very, very limited upper and have a lot of tone. Sometimes the feet, we're just going to let them be where they are most stabilized. And then we'll essentially kind of looking at the lowers as one unit, be able to use the uppers. So helping them get some stability for distal function is really important. And then pressure management or pressure distribution as well as comfort is always important. So the important part about 24-hour position is that we spend so much of our time during daytime position with the equipment that we're in, and we forget about the position that the bodies are in at night when they need to rest and for function. So thinking about positioning in and out of the wheelchair and the consequences of only addressing position in the wheelchair. Some individuals that we get that have been spending a majority of their time in bed, and now we're trying to get them upright, we find that they have that forward shoulder, they might have their curved trunk, they may be posterior because they may have been in supine for so long. And so we're trying to reverse those when we're doing the seating. If you think from seating to bed, if we're really meticulous about pressure management, pressure distribution, but then we don't have a plan for bedtime, then we're not supporting what we're doing during the day. This picture here is a kiddo that has a specialty mattress. And what's going on here is he has his left leg up on this platform and his right leg underneath so that his knees aren't touching. You have some wedges here, and then you have some wedges that you can side lie. The challenge in the States for 24-hour positioning is funding. And so sometimes what we're doing is doing a lot of coaching to the families on things that they can get inexpensively. And IKEA, that is now spreading around everywhere, has some really good bolsters and pillows that people could use for some of the positioning. So just be mindful of how we're carrying over that good seating into the bedtime position. So when we're looking at wheelchair seating, we're going to do a thorough assessment. We talked last week, my days are all blurring in, but a previous lecture on what problem are you trying to solve. So really get a good interview of what are the challenges, and then get a good hands-on assessment. You need to define position challenges and the cause of those challenges, figure out where it's coming from. If somebody has a pelvis asymmetry, it could be coming from the legs, maybe they have a leg length discrepancy, or it can be coming from the back, maybe they have a scoliosis, or maybe they have a contracture in the pelvis. So trying to break down where is it coming from. Look at developing strategies to address the challenges by keeping in mind what your goals are, and then match your product, the angle, support, service, and component to the individual problem. For the therapists that are on here, as we get more and more involved, and if you're in seating and positioning and develop your ATP, you're going to become really well known on all the products. When I teach to a generalist clinician, I say, think on the principle and the feature that you want, and the supplier will help you match to the product. So the supplier is really the one responsible for the equipment, and the therapist is for the clinical assessment. But we end up crossing the lines a lot because therapists get comfortable with a certain product, and suppliers sometimes may sway away from a product because there is limited funding. So we have to work together to communicate when we want to give and take when it comes to matching the product. We've talked about the client caregiver interview. How are they doing in their equipment now? How was it a year ago from now? What are your challenges? I mentioned about a mat exam. I'm a very big proponent on getting that person out of their chair so that you can see what's happening without gravity. And I'm also a big proponent of measurement tools. You need to have really good measurement tools to give you quantitative assessments, and no measuring tapes that are cloth or the clinky ones. We need to use rigid calipers and metal measuring tapes or yardsticks. We need to use goniometers. We need to have really good objective tools. So with the mat examination, you're going to look at what tone. Do you see any tonal patterns get get facilitated. You're going to look at their motor control. You're looking at the different postural patterns. You're developing any limitations in joint deformities by doing a full range of motion. And ideally, you want to put the person in supine, and then you want to bring them up to sitting. The reason that those two help with each other is that supine gets gravity out of the way and allows you to see what the range is. But then sitting helps you see in either a supported or unsupported manner how, with gravity now into the picture, are they sitting without the influence of the equipment. So you really want to problem solve on maybe what is causing them to sit a certain way, not just the symptoms. And that's where I like to go back to how did they sit when they came in, because sometimes somebody may not have any specific findings on the supine eval, but they may have a position of comfort or fatigue level. So is it in the morning? Is it late in the day? And then they may end up migrating to that certain position. So I mentioned about assessment tools. Some facilities have access to something like this, which is a planar simulator. Some people have access to more contoured. We use, as far as the planar system, we do have one. We don't use it as much as other facilities may, because we are lucky that we have access to a lot of equipment. So if you don't have a lot of equipment on hand, this can be a really good tool, because you can essentially build it up in a way that you're trying to simulate what components you want together. The contour system, which there's different manufacturers that make it, we definitely do this for custom mold, but sometimes if we're trying to decide if somebody could be an alternate drive, we need to be able to get them positioned with good proximal stability. So we'll actually use these mold bags and we'll put them in the chair and get them positioned, and then see how they do with access switches. Pressure mapping. So this bottom right is a pressure mapping tool. Pressure mapping is great for objective data, and it's great for recording a story, and it's great for looking at a lot of technical components for problem solving, but it's also very, very expensive. So I know that a lot of suppliers seem to have had pressure mapping, but I'm not sure if that norm continues because it is such an expensive tool. If you are a clinician that is more in the field and you're not going to have access to that, but you know a supplier may, collaborate with them and together work together, because what pressure mapping is interpretation of how the person's seated surface is being presented. So for instance, this neoprene mat has sensors in it, and I would put this between the person and the cushion. So I have the chair, I have a air-filled cushion, I put this on, and then the person sits on here. It sends a image to a computer on the perpendicular forces, and it can show you where there might be hot spots. Sometimes the hot spots validate, yep, that person has a left IT sore. Sometimes it says, oops, this is a high area, and if they don't have a sore, there's a very high chance of getting a sore in that area. So we use it for a lot of problem solving and a lot of cushion selection and a lot of like pressure management. With some of the manufacturers, you can do what's called a seating coach. So you can program in the sequence of that person tilting and reclining, and have a thing called memory seating. Sure, thanks for letting me know. Is this better? And then your hands. Your hands are the best assessment tools, but the challenge is it's really hard to quantify. I want them to sit like this. Taking pictures so that you can show where the positions are, so that when you want to install laterals, you can see where, like, take a picture and then you can measure and then you can write on the picture. Sorry. Here's the closer pictures of the simulation. So this is the contour. I think this is a contour U, but this is a custom contour. So if you have not seen it, when there is air in it, it's like a bean bag. So there's a lot of air, there's a lot of materials that is kind of simulating like a bean bag. So once you position the person, then you get them sitting where you want, and then you reverse the air so that you open the valve and the air starts reversing. As the air leaves it, it creates a solid foundation for that person to sit. Alternate drive definition. We'll get to alternate drive a little bit later. What is an alternate drive? Sorry. If somebody needs to drive from their a head array or a mini joystick, if they need to drive from a mechanism other than the joystick. Does that help you, Leah or Lee? And then this is a closer picture of the simulator. And so if you can see on here, it receives any type of, like you can put any type of lateral, you can move, see how right here, you can move the laterals up and down, you can move them in and out, you can add any type of armrest, you can move it. It's very modular, so you can add pieces and parts. You can add any headrest, you can move it up and down, back and forth, and you essentially can create a simulated position to see if that's solving your problem. So, define challenges. We're going to go through each of these positioning challenges and the cause. Usually, the pelvis is going to be associated with trunk challenges, and so I always start with the pelvis. And so the sequence of this is pelvis usually starts with the trunk, and then it has trunk, then it has lower upper head. We'll kind of talk through some of these scenarios, but I usually do pelvis, legs, because I'm looking at the thigh midline, and then the feet are usually not that big of an issue. They're either going to fall into place or you're going to have to do custom. Then I work up the trunk. But let's think through that on if we can define that sequence very specifically. Couple of resources. Invacare has a matrix clinical seating and positioning guide that's available through the Invacare Corporation. And then Permobil has 2 resources, and in fact, they just updated. I'm looking at that. So see, this one says Permobil, this says Comfort Company. It was actually developed by Comfort Company, and then when they got bought by Permobil, it's all on the Permobil website. They have one for long-term care. So this is seating and positioning, long-term care. They have one for just seating and positioning. They have one for wound care. And then they have a product selection that is similar to this one for long-term care. So I have both of these and the wound care one, and I refer to them and use them in teaching. If you're a visual learner and you like pictures, you will like these. So you can download them for free, or you can order a hard copy. So going through the body landmarks to get us all on the same page. So this person is looking forward. I'm looking at their left side. So their pelvis, the PSIS is posterior sacral iliac, and then ASIS is anterior. A lot of times we put our thumbs on the ASIS. Sometimes we forget about where to look for the PSIS. When I first started, I always had 2 therapists at every single eval. I had the OT, the PT, and one of us looked at the front, one of us looked at the back. But then we ended up with times and efficiency. It's usually only one clinician. So if I want to find out what's going on in the back, I may have a family member sit and stabilize the person and then be behind them. So don't forget about the PSIS. I feel like it is a little bit forgotten. We do spend a lot of time getting on landmarks with the ASIS. So the femur, this is your leg bone, and then the greater trochanter fits right in the socket here. And you may find a pressure, this is a pressure area here when someone's sidelines, or if they're too tight in a chair. Ischial tuberosity is our sitting bones. If someone's sitting upright like this picture, they're putting a lot of pressure on their ischial tuberosity. So there's a left and a right ischial tuberosity. There's also a left and a right ASIS as well as PSIS. And then the sacrum kind of hangs down here. When someone's sitting upright, they're really not putting a ton of pressure on their sacrum, but most of us don't sit upright. And so a lot of times we'll what you call sacral sit. So this angle here is opened up, and so they're sitting on this tailbone, and that can be also a cause of pressure. And I'm going to go through a bunch of pictures to describe when something isn't symmetrical. So then when we're looking at the trunk, you have your cervical, thoracic, and lumbar. If you go back to the spinal cord injury slide, when you had cervical injuries, C1 through C8, it's pretty much up through here. I always like the trick. If you feel the back of your neck, where your neck kind of meets your back, there's that bone right there. That is your C6-7. So if you want to think about how high a C2-3 injury is, it's pretty high. It's pretty up there. So your cervical area is kind of that neck area, but C6-7 is that little bump that we have. And then we have thoracic, so T1 through T10, and then we have lumbar, which is L1 through L5. Challenges. So remember, look at this pretty nice sitting upright. None of us sit that way. So what happens when we sacral sit is, see how that bone ends up having the pressure? So your ischial tuberosities may not be the weight bearing. It may be your sacrum. And so in the picture here, you have this open angle. The shaded area right here is when they're sitting upright. So when they're completely upright, they have this pressure point. As soon as they lean over, this becomes more forward, and then this becomes the pressure point. If you're doing like a seating, trying to figure out where that person seating is, that's where your hands come in. I will stand behind the person and kind of get my hands down and just feel where their position is or where that lowest bony prominence is. This is another picture. This is a little harder to see because of the person's clothing. If you follow kind of the spine, you think about the spine, they're really sitting on their sacrum a little bit. So when you want to look at problem solving, the solid back tends to always sit in front of the canes, and it can push someone forward. But if you look at these canes, if I had to draw a line, like a plumb line right here, this is a pretty decent back angle that's opened. So couple solutions is if they really need that back angle open for stability, then you can take that solid back and maybe move it forward to give them a little bit of lumbar. Most people need that lumbar support in order to try and offload that pressure of their bottom. A lot of times people seek stability with posterior pelvic control, and it works for some, but it can create a problem, and you need to be really aware of the sacral sore. The very opposite is anterior pelvic tilt. If you look at this lumbar area and look at this pelvis, that pelvis is pitched forward. Now for pressure mapping, what I see is if I can get the pelvis forward, you're also not putting bony prominences there on the ischial tuberosity because you're really offloading that. But this is too far anterior, and it's creating an extension in the lumbar spine, and then you have that visual field. The person here that we kind of have the head cut off, look at how lordotic they are. That's pretty lordotic, but their head position, I would bet, is perfectly fine. You see this a lot in muscular dystrophy because they get that proximal weakness and they're gaining that stability by arching their back. The challenge in seating is you have to close that angle to fill it in to give them stability. You can do that with like a, what's it called, a split back, where you have support up here and then you have lower support. But then you have to remember that you want to give them like a courtesy, I'm trying to think what it's called, courtesy flap, where we don't want their bottom hanging back behind the chair. Some of the kids with muscular dystrophy, they just don't want any contact back there, and they often don't like it. So when you're doing your trials, sometimes if you put too much contact, it'll make them go even more forward. So the anterior tilt is often a result of stability. You don't have trouble with pressure distribution, but you have this arching, and then you can create some visual field challenges. Obliquity. So remember that PSIS here and here, and then when you're in the front, I usually have my thumb over the ASIS. And so what you want to do is, if you look at this picture and you draw a plumb line, like straight across these armrests, you see that this right pelvis is lower than the left. And then what's happening on the bottom is you're putting more pressure on the right ischial tuberosity. So oftentimes when you're having a pelvic obliquity, you're going to have immediate problems with the spine. And so that's where our hands get in. So we want to see, do they have flexibility in the spine that maybe they need lateral support because they're trying to gain stability by leaning. You do see this a lot with like someone in a power wheelchair because they may be leaning to the right, and that may be how they are gaining stability. But when you're describing it, I always tell people to name, like the textbook says you name it to the lowest side, but I always say right lower than left by X inches. And if I draw a line here straight across, and I can decide what the difference is between that right side and that left side, and I'll say right lower than left by 1.5 inches. And then you want to see if that can be corrected or if it's accommodated. Here's another picture of a real person. So this is a left pelvic obliquity, and you see what's happening here. And now you start getting worried with skin on skin. So you want to try and get a lateral here. And usually, like, this is where you could do a 3 points. I might do one here, I might do one here, and I might do one here. But you want to see what is going on here at the pelvis for the flexibility. Because if they're not flexible, then they're going to overcompensate. So you definitely want to do something, because that's going to end up being a point of breakdown. Rotation. If you stand above somebody and look down, this is where you see the rotation. Sometimes it may look like someone has a leg length discrepancy, but this is where you want to see where is it coming from. This person has a left forward rotation, right posterior, and I would call that about 1.5 inches. I would even call that 2 inches. And then what they've done here is they've cut out the cushion to accommodate for that. So thinking of all the different planes here, you have your obliquity is your left and right, up and down. Your rotation is forward and back. And then you have your anterior posterior. So anterior posterior is rocking forward and back. Rotation is rotating left and right. And then you have your obliquity, which is lateral. Trunk. We saw someone that has a pretty lordotic trunk. And these are tough because these are standing, but you can carry them over to sitting if you are creative with your mind. Scoliosis is where you see that posterior hump, and then we've already seen some scoliosis pictures. So you need to be able to describe what you're seeing in the position to be able to defend what justification for equipment you're going to get. Some more pictures. This is a real severe scoliosis. So here's more mild. So this is an upright trunk, and then you can see where they're starting to have curvature. Describing in objective ways what that curvature is really, really important. Some funding sources will ask for a Cobb angle. A Cobb angle can only be done with an X-ray, and it's a scientific definition. Like, this is a very severe scoliosis, and so if you need to have a Cobb angle, it can only be done by X-ray. Here is kyphosis. So You do see this a lot with the elderly, with aging. I feel like we're seeing a lot with the computer and the gaming. I'm always telling my kids, sit upright, sit upright. Because instead of leaning over looking at your phone, you need to look upright. So this is something, if you can see where her ear is compared to her shoulder, her ear is pretty far forward. And so with seating, we need to make sure that we're accommodating for that so that we're not pushing them more forward. Another picture of lordosis. And then this is a picture of a kiddo sitting in rotation. So the sequence is, okay, have them sit to their position, and then I see if I can line up the pelvis. So if you can see this looking downward, his right side is pretty far forward compared to his left. So I have my thumb on his ASIS, and I'm trying to find how, like, where that position is. This is a really good picture of a rotation. So you see it's kind of that twisting. Look how forward his shoulder is. So his whole trunk is rotated, kind of twisted this way, and it's all coming from the pelvis. So back to those principles. If it's fixed, then you have to accommodate it. You don't want it to get any further contracted. If it's flexible, you need to find out, why is he sitting this way? Does he have pain? Is there anything related to his condition? Is there a visual field? Is it, pain, comfort, same thing? But you want to try and find out the cause for it. I am hearing a little bit of echoing. I just want to make sure. Can you guys hear me okay? Okay. This is actually you hear the echoing too? Heather, maybe if you can see if everyone is muted.
Will do. Yeah, it was just very slight, and then it's been getting a little bit worse.
Okay. I always feel paranoid it's me. Dominic. Okay. Mute yourself, Dominic. Someone pulled on you. Aldrich pulled on you. Can you tell Heather? It's Charlie. I'm one of the Charlies. You're the teacher's pet. Thanks, Aldrich. I remember that. Okay, let's go back. This kiddo. This was a mission trip that I did, and this guy is very, very windswept. And so I wanted to show you a picture of the windswept posture. So part of the problem is that he had very hypermobility to the left, but then he couldn't come to midline. And when he was in bed, he was just completely curled over. Well, a lot of these wheelchair distributions have people that have good intentions but no seating background. So this was an orphanage, and they were really, really bothered. I ended up lowering this footrest here. They were really bothered that the footrests weren't the same. So what was happening is people kept adjusting the footrest, but it was creating that windswept ability. So I needed to drop this footrest so I can get this knee in midline, and then the same with this. He was very, very sacral sitting and couldn't sit upright. But when it came to right here, that rotation left and right, he was extremely flexible. So even though I couldn't change his posterior pelvic tilt, I want to make sure that I can get this as much in midline as possible so that I could prevent him from getting further contractures. So I like this picture too. This one, I would bet there's hypermobility on this right side, so it really pulls in. And the left side is probably not that bad of trouble, but what happens over time is that this leg ends up pushing this leg, and you get what's called that classic windswept posture. So looking at the cause of it, sometimes you need some nice hip guides back here as opposed to knee guides. But these are usually pretty correctable. But this is a classic picture of a windswept, so I wanted to include it for all of us. We're going to go through hip abduction, flexion, knee extension, ankle. I love all this stuff. So tell me if you need me to slow down. Okay. adduction, add towards the middle. So if somebody lacks adduction, they are sitting in abduction. AB is away from the midline. That makes sense? So when you describe it, you need to say if they need adductors, that means that they need help adding to the middle. If they need abductors, it means that they're too cross, they need to get their legs away. This is another little girl that I worked with. She was a little wet noodle. And so she had very, very, very low tone. Can you see that abduction? She was just a little wet noodle is all I can say. She also had a really poor seat depth. And so she had nothing under her thighs that were supporting her. And so all we need to do was right here and right here, we put some adductors and we brought her in midline. Another girl that I worked with, she was severe adduction. So do you notice how her legs are crossed? What she does is she does that for stability. Look, she has no foot support. These are the footrests here, but if you notice, her feet cannot rest on the footrest. So when she rolled into the clinic, I mean, this is our clinic. We didn't have a whole lot of space. I needed to find out what was going on. She's sitting in a little bit of posterior tilt, pretty darn good trunk control, sits with her legs crossed, feet are on the footrest. So the main cause is that she had, I don't know what came first, but she had extremely tight hamstrings. Because of her tight hamstrings, her feet did not rest. Because her feet were not resting, she needed to cross her legs for stability. And over time, she had very, very tight adductor muscles. And so this is pretty severe adduction. So the first thing we needed to do is see if she's flexible, which she was still pretty flexible. So we talked to the caregivers and we talked about a stretching program, but they were really scared to hurt her. They didn't want to hurt her. And so what I explained to them is that for females, well, for everybody, but for females, hygiene is going to be a big issue. If we can't get her stretched out and she continues to sit and strengthen her adductors, we're not going to be able to help her with her hygiene. So we were able to get her midline, but we couldn't do it until we got some foot support. When we talk about hamstring tightness, I want you to think about this. Her foot could not reach this foot pedal because she only had 90 degrees of range of motion. So I needed to move the foot pedal to her. So we created a midline foot support that was literally underneath her feet that gave her stability. And then we put a very small abductor because we want to abduct, move her legs away from each other. And slowly over time, we hope to remove that abductor. Sometimes by putting something between their legs makes it worse and it makes them cross even more. So you have to do a trial. This girl, look at her head. I wanted you to see a picture of laterally flexed. So right here, it's laterally flexed. And look at her visual field. Look at where her chin is. So this is called hyperextension. She also had a little bit of a deduction. And, but if you look at this right leg here, if you can see it, she actually has a little bit of internal rotation. So internal rotation because her thighs kind of rolled in this way, and she also didn't have any, she couldn't sit on her footrest. So she was pulling her legs back, and they put this pad here because her feet were hitting the casters. But what we need to do is we need to see what the range of motion is in the pelvis. And this is where I work down to the thighs, get her some proximal stability on her feet so we can get her a nice midline, and then we can work with the trunk. She had pretty symmetrical trunk. She just had hypermobility, so we had to give her some head support and some neck control. So going back to the hip flexion, if you have, sometimes I ramble, so I'm just taking a deep breath. So you have your pelvis, okay? So if you are sitting at 90 degrees, which is you're sitting upright, But if your back angle, so if I'm going to draw from here, sorry. If I go from here and I'm going to draw like a plumb line this way, I'm opening up that back angle 110 degrees. So if you think about it, from where that position of comfort is to the thigh, that back angle is 110 degrees. So somebody can have limited flexion and they can't tolerate being upright. So what you need to do is you need to open the back angle so they're not falling forward. Let me go back to that lady with the kyphosis. Her. So do you see this angle here? So this is the angle of the back cane. And if you did a plumb line that goes straight up that way, that would be 90. So with her, I don't want to get you dizzy. With her, that back angle needed opened up. And so she had a more open seat to back angle, possibly because of contracture that limited the hip flexion. And this guy here is the same way. He's really sacral sitting because he has really tight hip flexion. So he is fighting against that back, and that red line is a back at 90 degrees, and it needs to be open. The interaction of the hip and knee range of motion. So we just talked about the back. Now, if I'm looking at the hip and knee, if somebody is sitting at 90 degrees, so if I take their legs and I can bring them up, they have flexion here, so they don't have hip flexion contractures. I can get them at 90 degrees. When I take the ankle and the lower leg, I should be able to do a straight leg raise to at least 110 degrees. If I can't, then I need to adjust this footrest. Does that make sense? So when someone is sitting at 90 degrees, I should be able to get the foot out so this angle here is at least 110. Both of this girl, if I could do 93, 94, I was lucky. So I needed to bring that footrest back to her because she doesn't have the range of motion to sit for that foot to sit out. Same thing with this kiddo. So she has probably a 90-degree knee flexion here. I need to see what's going on at the hip before I test, because if I don't pay attention to what's going on the hip and I just pull the leg out, what's going to happen is it's going to move as one unit. This entire pelvis is going to come, and so I may have 110 degrees of knee extension, but now I don't have 90. I might have 115 degrees. So you always want to look at what position the pelvis is at and where they can tolerate their lower extremities. What questions do you have? That always generates questions, and we'll see how clear. This is where it kills me to not be in front of you guys because I want to do a lot of simulation. How am I on time? Oh, not too bad. Okay, I'm going to keep going. These pictures just explain the dorsiflexion. So you have range of motion where your toe can come up to you. Plantar flexion, where you extend it, your toes can come down. Right here, that's plantar flexion. He lacks dorsiflexion and he has tight plantar flexion. Oops, I'm going to show you. She has pretty good ankle range of motion. There's no problem there. Inversion and eversion, I think this is really confusing, so I wanted to give you these pictures. So eversion is when your foot comes out. Inversion is it when it comes up. It's different than pronation and supination. So I have high arches, and I always end up supinating my foot, and then I have ankle trouble. So supinate, I always think of holding stoop for your hands for supination, but it's that turning. So high arches, a lot of times your foot will roll out. Sometimes they say low arches, your foot rolls in, which is pronation. It's different than inversion and eversion, but it could be very confusing. I hope you like those pictures because it's hard to describe. So now we've gone through the lower extremity. Now we're going to go through the upper extremity. So shoulder, we have, if your shoulders are pulled back, you have some retraction. So it's a deduction. So your scapulas are coming together. If you have depression, they're down, elevation is up. Sometimes you're not going to see this in symmetry because it may be because someone had a stroke. Protraction, so abduction, where the scapulas are far away. Sometimes you see this with kyphosis. And then this is upward and this is downward. So those are the scapula movements. Elbow, flexion and extension, pretty easy to explain, but you want to look at that range of motion because if you're looking at joystick driving, as far as access to the joystick or switch control or computer access, if somebody doesn't have full range of motion, they can become contracted, which may interfere with some of your devices. Remember I said holding soup? So supination, you're holding soup. Pronation, your palm is down. Sometimes with spinal cord injury, you see this. Sometimes they end up resting. And this is, you, as a spinal cord therapist, you have to be really, really aware of this because if somebody is resting in supination, how are they going to drive that power chair? How are they going to access things? So we want to splint, train, strengthen, do whatever we can to keep them in pronation.
Teresa Lee has a question.
Question? Okay, let's see. I knew there'd be a question about that. Okay. It makes sense to me to focus on the pelvis. Do you focus on 110 at the knees? Do you keep the hamstrings a bit more stretched? I always thought the focus was 90, 90, 90. Where 90, 90, 90 comes from is spasticity management. So when you talk about tilt in space, your hip angle, your knee angle, and your feet are all maintained at that position. Never really thought about that with the hamstring, but separate them. So 90, 90, 90 is related to a tonal influence. You definitely, when someone has a lot of spasticity, you want to keep them in a closed position with 90 degrees of hip flexion, 90 degrees of knee flexion because you get illicit spasticity. But the 110 at the knees, what that does is it allows them enough range of motion to rest on a regular foot rest. So a 70-degree foot rest requires 110 degrees of hamstring length. That doesn't mean that they can't have more than 110, but if they have less than it and their feet are falling off the footrest, it's because they can't reach the footrest because of the shortened hamstring. Does that help, Lee? If they can't get 110 straight leg raise, they don't have sufficient, probably. So if they can't get 110 leg raise, what's going to happen is you're going to end up compensating by the pelvis. The pelvis is going to come out to meet your legs. So you could either, that's in 110 is a 70-degree footrest. So you can get like a 90-degree footrest and not have to do custom order, but you need to make sure then you're not hitting the casters. So I would say tilt and space chairs is when you see this the most. And most tilt and space chairs are sitting high enough that you shouldn't have to worry about the casters. But you can also have it with somebody with like a spinal cord injury that has a lot of spasticity. And so their feet are constantly falling off of the footrest. So you need to bring the footrest to match where their feet can fit. But you're exactly right. If you can't get 110, then they may not be able to sit at 90, or they can only sit at 90 with their feet at 90 degrees. And if you want to unmute yourself, if I've completely confused you, feel free to do that. Oh, because that's Adrian. Do you want to unmute? Okay. You're good. Thank you. Head support, here's some positions that you see. That little girl that I had pretty severe neck extension. She was also laterally flexed. You want to look at what head supports or neck supports. We ended up doing a decent neck support for her because she didn't have any of the muscle intervention to be able to maintain that upper extremity head position. And then I got this from the wheelchair seating positioning guide that I said for you guys to, so it shows you kind of if you want to see more examples. So you want to develop positioning strategies. You want to keep your goals in mind, remembering what problem are you trying to solve. You know, if you want to do custom, you just need to make sure that you've well thought out anything that's off the shelf. Even if somebody maybe could use an off the shelf but would not be able to sustain it due to wear and tear or fatigue, just tell your story when you're trying to get the justification. The biggest thing is you want to be able to explain how you've arrived at your conclusion. You know, going back to matching the product to the angles, orientation, support services, and components, and looking at pelvis, the seat to back support, looking at your knees, the seat to lower extremity, and looking at your ankles for the lower extremity to foot support. Making sure that the support surfaces are addressing tilt as well as recline, and looking at the seat to back angle on the orientation of the lower spine and available movement of the joint. I talked earlier about closing it. So if I want that angle to be less than 90 degrees, so meaning that you're really pushing that forward, you may want to do that to inhibit extensor tone, like that 90-90-90. Sometimes if you need to get them upright, but gravity is going to be their barrier, then you can use tilt to kind of get them to sink within it. So looking at the combination of your seating systems, and depending on what your tasks are, you can use some of those combinations. I feel like we talked about the open angle a lot. You know, the knee leg support, these are just some duplicate slides. Depending on your movement, the hip, knees, and your orientation of the support surface. For your knees, you're thinking of seat to lower extremity. So if you have a closed angle, so your feet are closer to the chair, that's where you're relieving the pull on the hamstrings, but you can continue to lose range of motion. And as I said, you have to be aware of the casters. If somebody has extension, which I didn't have any pictures of, then that's where you may want to use elevating leg rest just to get them out to that position because they may not be able to come in. Anterior tilt of the thigh, Olga, is it's bringing it forward. So you're closing the angle. You're closing the angle of the trunk, and it's like pitching them forward. If you think of one of those lazy boy chairs, how it lifts you forward and up, that's an anterior tilt that you can create in the power seat. I'm trying to find where it said anterior tilt. So, so if you have a closed angle from the pelvis, so your trunk to pelvis is 90 degrees or less, it will disinhibit extensor tone. You can use tilt to prevent them from falling forward, but then you can also use anterior tilt, meaning that your knees are lower than your hips. Does that help, Olga? Lower extremity support really depend on the available movement of the knees, ankles. Just don't use the equipment to stretch the person. I see that with ankle huggers and straps. Sometimes someone's feet falls off, so they want to solve that problem, but they don't understand what the cause is. A closed angle of the ankle can be with dorsiflexion. They may not have the range available. Sometimes it can break up an extensor tone, and sometimes, well, a lot of times you use angle adjustable foot plates. An open angle is plantar flexion, and we need to make sure that we have enough ground clearance. A recline So you have the back moves independently of the seat. So this is an open angle. So you can open the back angle, but you're maintaining the seat in the footrest. You want to open the seat angle for catheterization, for pressure redistribution, for weight shift. If someone has a tray and they want to have that tray parallel to the floor. If someone has low blood pressure, so we talked about that with the spinal cord lecture earlier on. If you want to allow passive range at the hips and knees, and sometimes transfers are easier. A con of a recline is that the shear forces can disrupt alignment. Reclining increases pressure over the sacral area. Sometimes when you open that back angle, you can get extensor spasms. And you definitely can't use it with a contoured positioning because you lose your point of contact. And then you can't use it with systems that have fixed seat to back angle. A con to a recline, someone that has limited range of motion or their knees may be pulled out of position. So that may be their only way of pressure distribution. And so that you definitely wouldn't want to create that. And then also, if you recline back, now you've pulled them away from their different assistive technology, so they may not be able to use a communication device. Tilt is if used as one unit. So you have the hip, the back, like the hip position, the knee position, the ankle, all moves as one unit. Here's a anterior. This isn't severe anterior, but the hip is higher than the knee. So you pitch it forward. Lateral tilt. So this is where it moves side to side. I've only used lateral tilt maybe 2 times in my career. I initially understood that lateral tilt is good for if you really look at the definition of like with someone with a lot of lung and respiratory issues. It also, the one person that I used it for just couldn't, it was the only way that they could get relief. They had a lot of complications and they couldn't do a tilt. And so the lateral system you can put on to to different bases. Ideally, use the closed angle dorsiflexion if angle can achieve 90 degrees, and use an open angle if the angle is fixed in flexion. So Olga, are you asking or are you wanting to confirm that? Use a closed angle dorsiflexion if they can achieve, if they can achieve 90. Use an open if the angle is fixed. Yep, you got it.
Okay, thank you.
Sure. So the tilt, all angles stay the same. Pros, it redistributes pressure. You are inhibiting muscle tone and maintaining posture. You have very limited to no shear forces, and everything is staying around you. Tilt systems accommodate contoured custom seating wonderfully, and you don't have any range of motion limitations. Con is that pressure relief is not as great as with recline, and that can be debatable, and I'll talk about the combination in a minute. A con, you have to move away from your work surface, so that's true, because you can't tilt when you're at a desk. You have to be aware if you have stuff on the trays, it needs secured. And there is a theory that maintaining the hips in a flex position can constrict the bladder, and you may have some leakage with a leg bag. So those, I agree with all of those. Lack of movement at hips, knees can lead to range of motion loss. Yes, but again, we should be stretching the person, and we have that 24-hour positioning. Some tilt systems have a higher seat to floor height than reclines, which is true. And so sometimes that affects transfers or clearance under tables. I would agree with that. Here's my golden nugget. This is from the Resna position paper on applications of tilt, recline, and elevating leg rest. The research has shown that tilt when used alone must be greater than 25 degrees. Recline when used alone should have angles greater than 90 to 100 degrees. But the greatest reduction in pressure relief is when you use tilt and recline together. So ideally, you want to tilt 35 degrees with a recline of 100, or you want to tilt 15 to 20 degrees with recline of 120. So this is where manufacturers that allow programmability within memory seating, you can fine tune this to have that person get the best combination. So we just went through pros and cons of each of the systems, but I think that they're all best when they're used in combination. So I would really encourage you to take a look at this position paper. It's all backed up with literature, and this is my best piece of nugget of information. Let's see where I'm at. It's 8:30. Orientation. I feel like I'm. Can you guys hang in there for? I only have like 5 more slides, and not even that because we have the test. So support systems, linear or planar is a flat. Contoured is going to have more this. This is a molded, but contoured is going to have some impression. And then molded is what this is here, and there's all kinds of different materials. Because the exam is more principles, they're not going to go over products, but you just need to understand that there are differences in support systems. Componentry, as long as you describe what it is that you want to achieve, there's going to be a component that supports that. You need to think of the different feature that you want for the arm support and the features that you want for the foot support. And then if you want upper extremity supports or lap trays, and how that's gonna help you. Again, really encourage the use of all these position papers. We've given you a baseline, but even some of these position papers are considered advanced. But if you want to overstudy, you can go look at those position papers. There's wheelchair standards with seating, and there's measurements. If you want to look at the standardization of measures in different terms, this is definitely advanced. But if you want to peruse this to familiarize yourself with some other languages, or look at some of these have a lot of really good pictures. So let's go to the test, and then we'll take a break. So I'm going to launch the test. So it says in progress, so I hope you guys can view it. Okay, some people have submitted it, so I think you can view it. This was the biggest part of the lecture tonight. The second part is not as heavy. We got that out of the way. We're going to try to get to 70% submitted, and then I'll close it. Yeah, a contoured, so to differentiate while we're waiting between a contoured system and a molded, a contoured has shapes that are very similar. I'm going to go back to the very first picture here in our so if you look, this is a contour, and this they've carved out more specifically, but it has the contour where it has a weld that's here, and it has a spot for your thigh. they've done more customization, but even if they didn't carve this out, and then the part that goes over it has contours that will accept the shape of your body. If you look at this as flat planar, so if it's not flat planar but has capture some shape of your body to keep the legs midline, to try to just shadow the shape of your body, that's contoured. When you get into custom molding, you are truly molding to that individual. And this is still a little symmetrical for a custom mold. The custom mold, you are capturing that person's exact body shape, and usually somebody is going to be a pretty severe position, like that spine that we saw earlier. I'm sorry if I'm making you dizzy. That person that had this spine, you're going to have to do a custom contour and mold around that position. So then the picture at the very end that has, that's a contour right here. So this is a contour. This is a custom molded. So molded is going to be a very severe representation of that person's posture. You can't recreate from off-the-shelf systems. I would say this is a contour. This kind of feels like molding. You can't see video. I don't have a video. Can you not see my screen?
No, we can't see your screen with the test open.
Oh, crap. Okay, let me shut the test. We'll take a break and I'll come back and explain it. Nobody was cutting me off. Sorry about that. Okay, let me close the test. Let me review it, and then we'll kind of come back to that question. Okay, pelvic asymmetries include, the right answer is tilt, rotation, obliquity. So a pelvic asymmetry would not include, pardon me? Oh,
we can't
share.
see the test notes. Yeah. There.
Okay, how about now? It must be time for me to get a break too. Pelvic asymmetries, so tilt, rotation, obliquity. So a pelvic symmetry would not include the spine, adduction, abduction, and flexion is just the thighs. So pelvic asymmetry, see how it's doing the pelvis here? Extension, flexion, adduction are also the lowers. So going back to what it's asking, an asymmetry of the pelvis is just going to be C. Number 2, that's pretty easy as far as you want to make sure you're addressing all three with muscle tone, range of motion, and postural patterns. Okay, we didn't do too hot with the functional advantage of an open seat to back angle. So let's look at this together. Improved head and neck control, increased extensor tone, reduced pull on hamstrings, and providing a task performance. So an open back angle, if somebody can't tolerate sitting upright and they're falling forward or they're not able to sit up, then opening up that back angle will give them a better trunk control, which is going to help with their head control. Opening a back angle can create extensor tone, so we don't want that. Open the back angle is not really, I'm just trying to think how the plausibility of your hamstring is really going to be your footrest, you're adjusting your footrest for what range of motion you don't have with the hamstrings. And then providing a task performance position. I don't know if anyone picked D. That to me can be confusing. I'd be curious on, and I know we're ready for a break, but I would be curious if anyone wanted to have a discussion about why we did so bad as a group on number 3. And I'm wondering if it's related to D or if people had different thoughts. So let's take a break. Stay on if you want to talk to me about it. It's 8:40. Let's reconvene at 8:45. Okay? So potty break, get a drink of water. This is a pretty tough concept. The back angle, Aldrich. So Aldrich, I'm biased because I'm very much a interactive learner, and so static slides don't do as well with me as pictures. Um, so I think it's just adding depending on your learning style. Where are the best pictures of combining recline plus tilt? Um, if you go to Permaville and you look at their memory seat function, there's probably a video of that. It's essentially the sequence is you recline and then you tilt, and then sometimes somebody might recline a little more. So it's kind of that sequence, but that's going to be really hard to capture in a like a slide. You would have to see that interaction. But memory seat functions is really what does that. And then the position paper isn't going to have any videos, but maybe there's some references to that. Maybe more examples in the solutions, like a before and after, Aldrich. Yeah, that's not a bad idea. So we can add some, here's the problem, here's what we did, here's the solution. Okay, we can add that. Oh, forward head by eating. Okay. Okay, we'll do that. Good feedback. Thanks. Okay, it's 8:45. I want to go back when I was rambling when you couldn't see anything. Can you guys see my screen okay now? I think you can see it. So what I want to show you is contoured versus custom. So this has some contour to it, not a ton of it, but you can see that it's a small adductor pummel. So this has some contour. This is a J cushion. So this is that well that I was showing you. So there's a well here, and then it has some slight contour, and then this is a overlay with the gel. I'm trying to navigate. This has some contoured seating here, and this is where it gets more into custom mold. So if you think of this position and like even this position, how there's some contoured, and then let me make sure I don't shut down the webinar. And then you look at this position here. Do you see how severely molded that is? So that's where that person needs enough external support that you can't achieve that from off-the-shelf seating. And so that's where it's more custom contoured. Make sense? Okay, so now we are going to go into mobility technology, and let me get, okay. So with this one, we're going to identify impairments that cause a person to need mobility. We're going to talk about the steps in assessing for mobility and talk about the characteristics and features in the different technology. So we're going to talk about the goal. We're going to also talk about the assessment, some options, and some considerations. So the goal for everyone is to independently move throughout their environment and complete functional tasks. So, you know, I look at a chair as allowing you to do those things in life that you want to complete and not do them with a burden. And we have to do it so that you're safe, so that you're effective, and you have good efficiency. Looking at the category of mobility technology, and that's where we go through the least costly alternative. And sometimes more than one mobility option may be needed. Funding sometimes is a barrier, but I always like to say don't let funding drive your decision, but be mindful of funding to make sure that your solutions are reasonable. So when you're looking at somebody's motor skills, we have to look at their strengths, but we also want to look at their endurance and their movement control. Our funding sources in the U.S. tend to get stuck when they see 5 out of 5 muscle strength. And it's up to us to quantify that and explain that even though somebody has 5 out of 5 muscle strength, they have poor endurance and they may have like apraxic movement, or they may have some difficult with movement control. We need to paint that whole picture on motor skills, because the motor skills for the strength, endurance, and movement may be the reason why we're rolling out a manual chair. But on paper, it may look like they can push a manual chair, but we really need to explain why they're having difficulty. Or in some cases, if someone has a cardiac issue and has like heart failure, or has different reasons why, even though they can push it, they shouldn't because of the endurance and the cardiac impact, then we need to be able to explain that. Vision and visual perceptual skills, we need to be able to rule out that there aren't any impairments. And sometimes we are doing this through a trial. And so we're having them get into a power chair. And if we see that they tend to be have an inattention to one side, we may want to go back and do some quantitative assessments. But I'm a big fan of trial, get them in the equipment, because somebody with cerebral palsy may not be able to complete the visual assessment or visual perception because of cognitive, but they may be able to learn cause and effect and how to drive a power chair. So I usually look at vision and vision perception. If they're failing at something, then I go back, but I don't spend a ton of time gathering a lot of content on where they're at. The cognition, they need to be able to understand mobility concepts, Obviously, safety is a big area, and they need to also demonstrate judgment. Options for mobility is assisted ambulation, so different assisted devices. Somebody may need a dependent mobility, so it may be a tilt and space manual chair, or it may be a upright chair. Sometimes when people are needing a just basic upright manual chair, they may not come to seating experts because it may be something that doesn't require a specialty exam, but we need to make sure that that system has the features that the family's going to need. The largest part of our time is spent with manual, power assist, scooters, and power wheelchairs. So when we talked about assisted ambulation, we're looking at canes, crutches, walkers, and gait trainers. Even though a gait trainer is assisted ambulation, with kids, I know oftentimes someone can have a gait trainer as well as a wheelchair. Most of the other populations, especially with like adults, they were ruling out the use of cane, crutches, walkers in order to move through the algorithm of needing mobility. Dependent mobility systems are not designed for self-propulsion. With kids, they could be strollers. With adults, they can be a transport chair, but then they also can be a tilt and space chair that has a lot of seating embedded in it. Dependent mobility systems are often found for clinical indications like a small child. It may be a caregiver's preference. It may be an ease of transport, and maybe it's a backup to a manual or power chair. I had a girl that I met. She just had graduated high school, and she was pretty proficient with a power chair. And the family was in the clinic, and they were just a really delightful family. And then they said something about getting another tilt and space chair. And I looked at them and I said, "You mean a manual, or you mean a power chair?" I couldn't imagine this person so independent in her power chair needing a manual tilt and space. And they explained to me that she has a lot of endurance issues. And if she's having a bad day or she needs not to be in her chair, that they find that the backup tilt and space manual chair is what's worked best for them as a family. So you're always learning new things out there, but sometimes dependent technology is for those specific situations. For manual chairs, a pediatric chair is going to have growth in it. So either the chair will have growth, or there'll be trade-in programs that will allow the child to progress through, and still you have the equipment where you don't have that 5-year window that we do for adults. The terminology lightweight and ultra lightweight comes from a Medicare designation, but often the manufacturers, when you say ultra lightweight, you're looking at something that has an adjustable axle plate, as opposed to a lightweight may not have as many options. And then the positioning can be a manual tilt, it could be a manual recline, and it can be a standing frame chair. When you're looking at the self-propulsion, you want to consider the weight of the chair, the rear wheel placement, and so where that person's access to the wheel is, so the relationship between where the rear wheel is to their shoulder. Camber, camber is if the top of the wheel is closer to them than the base, there's an angle, and so that's camber. If you think of a basketball chair, that's severe camber. Other considerations for self-propelling are the size of the front caster. If you have really big front casters, then that can affect your efficiency with propelling. If someone's weight distribution is sitting in front of the caster, that's what's called loading. And so you want somebody you have your center of gravity, so where that person's tippiness is in the chair, but then there's also a center of mass. And so the center of mass is where that person's proportionate weight is with the chair. Story: I had a guy today, T10 para, super active. His back angle was closed. We just talked about back angle. He had a solid back that was sitting in front of the cane. And when I looked at him, he just looked like he was really sitting real far forward. told me he had a hard time keeping his left foot on the foot plate. Hence, he had hamstring tightness. And so because he was sitting so far forward, he had to flex his knee to get his foot underneath him. So as I was watching him, I'm like, we need to get you back in this chair. So I took the, can you see me? I took the cane, and so it was a closed angle. So I opened it up to 90, and then I took the back that was sitting in it, and instead of being in front of the casters, I moved it back. That opened up about 3 inches to push him back. All of a sudden, his foot just laid on the footrest without any problem. Well, then when he went to push the chair, he said, oh my God, why is this so much easier to push? And I realized he was loading his front casters because he was sitting too far forward on the frame of the chair. My web, pause. Just when I'm trying to do pictures. Can you see me now? Can you see me now?
No, it's still not working.
Am
Mine
I
did that.
web?
Yeah, mine did that last week on me.
Oh. So essentially what I was trying to show you with my hands is that he was sitting in so far in front of the back cane that he was sitting on the forward part of his seat, and it was causing loading on the casters. As soon as I moved him back, his weight distribution was more even on the chair, and he noticed that he was able to propel it a lot easier. So I thought to myself, I wonder if I could work that into tonight, and I just did. So looking at efficiency for propelling and how this is all impacted, and I can tell you that this would be considered more advanced. I could ramble on this because I love it and I'm intrigued with it. But keep it simple. Know that there's self-propulsion. The weight of the chair can impact it. Your rear wheel placement, you want that wheel to be more underneath your shoulders. Your caster size can impact the propulsion, and you want to make sure that you have some good stability and maneuverability around tight surfaces. Manual propulsion, and this is where too, okay, Aldrich, this is where I feel like we need pictures too. So you can propel with 2 hands, which most people do. Someone that would propel with one hand, maybe somebody that had a stroke or somebody that had a rotator cuff issue. You can have a brain injury that does one-hand propulsion. A lot of times you see one hand, one foot, and so that is more classic of a stroke. But I have had more people than I've had more people recently with a one-hand drive than I have probably in the past 10 years. And so that is, you only have one limb for propulsion. And so then with the one hand, without having a foot, you need to be able to have a special chair that can accommodate moving both rims. And then you also have somebody that can use both feet. And I've actually had this quite often. So if they don't have the coordinations in their hands, sometimes people will propel with just their feet scooting around. I don't think it's a good long-term solution, but I do see a decent amount of people use this. So when we talk about pediatric, it's definitely looking at the smaller dimensions. The biggest thing about the pediatric is the growth capability. I have had like smaller stature individuals or very small frame, like osteogenesis imperfecta. I've had people that are just smaller frames that I end up getting a pediatric wheelchair. But, I've asked people, what really defines a pediatric wheelchair? It can be the smaller dimensions, but on the flip side, usually when you're talking about pediatric, you're talking about the growth and the ability to trade up the programs. So we've talked a lot about a tilt in space, and you see how high this is off of the casters. They're usually not going to be in the way of the casters. This is a manual recline. So we had that simulator that showed a manual recline. And this is a standing frame chair. So there are manual standing frame chairs. And when you talked about the function and the task I think that that's really what's important. My opinion, this is just my opinion, a standing chair is not a good everyday chair because it's going to be heavier than an ultra lightweight chair. But based on the situation and when the person is going to use it and the different manufacturing, there are situations where people use that as their everyday chair. Power, I'm going to say add-on. So we use, this is power assist is a very common word. So where the power add-on or power assist come is if somebody is a marginal manual wheelchair propeller, but really isn't ready for power or their lifestyle cannot accommodate power. So this bottom right was your typical power assist. This is the whole mechanism is the wheel. The motor is within the hub, and then it's activated by pushing this rim. So it reduces the amount of force, and it allows the chair to be propelled through a power mechanism right at the axle, and that it assists the person in propelling. A disadvantage of this is to disassemble this and get it in and out of the car. It's very heavy. So then on the market came this power add-on. So this is a quickie extender. They also, oh my gosh, what's the Emotion is the one that's on the market. And then there is a third one, Clifton something. The so again, manufacturing wise. Smart Drive is a power add-on. So this adds on to a manual chair, and then it's activated by a wristband. So when you tap the wristband, it turns this motor on, and it essentially is pushing you through your environment. This here is, I know Firefly is one brand, but this is an add-on system. So it clamps on to the footrest, and it lifts the casters up, and then you can power it. There's different types of styles. This one looks like it's like a scooter style drive. So power assists are really, really good for any shoulder function preservation, long distances, outdoors. It is pretty expensive, and so, you know, depending on your funding, some funding says that you have to be in a manual wheelchair for at least a year before they will consider it. Others will get it right away. But this has really opened up a lot of opportunities for individuals that their lifestyle doesn't support power, but they are really struggling in a manual chair. So the next step is scooters, which Medicare calls power-operated vehicles. So scooters are oftentimes a consumer preference because of the aesthetics. They tend to be more acceptable. They tend to look less medical. They have the better transportability than power chairs. Sometimes they're not as maneuverable. This here is I would say not your average. This is more of I don't think this one's a heavy duty, but the footprint of this is a lot bigger than some of the scooters that we see. I'm going to go back for a second, see if I have any other pictures of scooters in here. No. So most scooters, most of the problem with scooters is people want them to be so maneuverable and transportable that they're too small for the individual and they become very tippy. So the amount of distance that they can travel and the power and speed sometimes can be compromised, and sometimes the motors and batteries don't last very long. There are a gazillion scooters out there, and so the ones that are the most souped up are here. Let's go to the internet. Real fun to see all the different types of scooters. So as a medical person, you know, we need to be able to guide somebody on what that best scooter is for them. So like this is similar to the one that I just showed you, but look at how tiny this base is. So this scooter, if you have somebody that's really tall or really big, can easily tip, as opposed to this one with the base. I got everything. Power mobility scooters. this is what I was looking at. You got some scooters out there that are pretty darn creative, but obviously this is not going to be covered under most insurance companies. This isn't going to be covered under most insurance companies. This is not going to be covered. So sometimes people come in with an idea in their head of what they want, and we're saying, well, here's what you're eligible for. Sometimes they think maybe this is what they want, but because of their size and weight, we may have to get them into something that's like this. So those are some tidbits and tricks that I've experienced with scooters. So your clinical indicators are if you've ruled out manual wheelchair propulsion and you've ruled out any form of ambulation. You need to show that the person can safely and effectively use the scooter. I'm sorry. Okay, power wheelchairs, yes, safely use all manual wheelchairs, any power add-on, and you cannot use any scooter. You need to be able to show the person can safely and effectively use power wheelchairs for mobility. I want to go back to scooters. You also have to show the person can transfer on and off, and you have to show that they can use this tiller. So if they can't, and they can't transfer on and off, and the third thing is postural stability, that will rule out a scooter. So then you can go into the power wheelchair. You've ruled out the scooter because of those reasons. You've ruled out manual chairs. You've ruled out power add-ons. So when you look at power chairs, you need to think of the drive wheel configuration. This is a rear wheel drive chair. There are mid wheel drive chairs, front wheel drive chairs, and I'll shout out when we get to the different pictures. You need to think of the access. So are they using their joystick? Are they using a chin control, a head control? You want to think about the programming. So I've been throwing out the seat coach. That is a programming function. You can also program the throw, which how much of the joystick position needs to be changed for it to drive. You can do forward speed, rear speed, turning speed, torque. There's so many things that you can program to make it individual that you can't do in simpler chairs. If you want a power tilt or a power recline, that would be a positioning system. And then if you want to start interfacing with other technologies, such as a communication device or your cell phone, you need to be able to have more advanced electronics. So the drive configurations, I showed you a rear wheel. This is a mid wheel, and this is a front wheel. We talked a little bit about positions before. So this is a tilt. This is a lateral tilt. This is a seat elevator. Elevating leg rests are here. You have calf pads. And so this can extend up. This is a standing feature. And then I talked about anterior tilt before. Before you get into standing, you go into like an anterior tilt. What's preventing the tilted chair from tipping over? The one on the top left. You know, it's the actuators. Maybe Heather can jump in too. So the lateral tilt, is that what you're talking about, George? I mean, they're all very stable, and they are built in with the actuators and the mechanisms to have those safeguards. I don't know if Heather, you wanted to say anything from your engineering perspective.
Yeah, the weight of the base keeps the chair in place, and it's just the frame that's angling. So the weight stays centralized.
Thank you. Okay. And you know, Georgia, the good point about that is that when I talked about tilt and recline, most people don't tilt far enough back to get the true pressure relief because it feels very strange and they feel like they're going to fall out. So sometimes I will actually have like a family member sit in it, or I will sit in it to show them how far back they can go. I've also, if any of you have had manufacturing in services and they tilt and then they stand up and they push on the back to show it's not going to tilt over. A lot of people don't utilize the full features of the chair because it just feels awkward and it feels scary. So any teaching that you can do and any demonstration really helps with that. Access methods. So proportional and digital, and Heather talked about some of these in her access. So you're gonna have to correct me if I don't explain this right. But proportionate is essentially the direction that you want to go is where you point the joystick. So if it starts in the middle and then you push it a little bit forward versus if you push it all the way to the end. So the distance, which I've heard is throw. So how far forward you need to push it, and it's kind of like a gas pedal. You don't need to push it all the way to the ground to go forward. But proportionate is essentially whatever direction you want to go, that joystick is going to be proportionate. Non-proportionate or digital is where you have a switch for forward, a switch for reverse, a switch for left, a switch for right. So a sip and puff would be an example of a non-proportionate. So you do soft sip, hard sip, soft puff, hard puff, and it's breaking up the different directions. Here's my proportionate access. So joystick, and it could be a standard joystick or it can be this little mini joystick. And so the grading of force and distance of movement, and it has 360 degrees of control. That's kind of what I was trying to say. And you also have the speed control where you don't have to do pedal to the metal. You can just hit it a little bit. And when somebody first gets into a power chair, sometimes I have to take time to explain to them that it's not all or nothing. It could be gradual. And then digital is where you can use 1 to 5 switches to control the direction, and the speed is pre-programmed. So this is a sip and puff here. There's a switch on the right, a switch on the left, and this probably has a proximity. So if I want someone to start, they might lean their head forward and then they come back. And so that sets it to say, yes, it's ready. And then when their head is near the back, it is going. And if they want to stop, they pull their head forward. And if they want to go right, they hit the right. If they want to go left, they hit the left. And this is a beam. So you close. I'm totally blanking on how you might have to help me here. You're closing the beam for the bottom right, and so it might be programmed where if I'm covering two of the infrared versus 3 of the infrared, then underneath here is kind of showing you where some of the switches may be. You can have infrared switches. You can have proximity where it's sensing how close you are to that switch. I've had some people that have the switches maybe on this side of the tray, and then their hands maybe rest over the side, and then they have their fingers. And then this one, this is an ASL, and so this has the different directions: front, right, reverse, left. Heather, if you want to add anything, please do. Programming optimizes the drive performance and the efficiency, and it allows to control the other features such as speed, reverse, positioning systems. A lot of times if I'm doing an evaluation and somebody is struggling, I'm going to get in there and start doing some of the programming. If somebody is pretty intuitive and seems to be doing fine, I might have them, when they get their final chair, go out, come back for a 1-month follow-up and find out what's working and what's not. I feel like programming is one of the most underutilized options, and the features of this equipment are so advanced, and we fight for funding to get these things covered, but then somebody gets the chair and they don't want to come back for that advanced training. So we worked really hard in my clinic to bring people back to try and do a maybe a 6-month follow-up or a 1-year follow-up. If you have somebody that has declining condition, you definitely want to have some follow along so that you can keep programming it to keep them able to use the equipment. Infrared transition and mouth emulation are different electronic features. A lot of times these are compatible with communication devices or like on-screen keyboards. Interfacing technology. So using access methods to control other assistive technologies. This is example of, has like ECU 1, 2. You guys talked about the Tekla in one of Heather's lectures. So the Tekla is named, it's a specific manufacturer that works with Invacare, but you can work with any of the chairs. It's bringing together different devices. Environment, so thinking about if that person's going to use the chair in all the environments they need. We really focus on indoor mobility because that is what our funding directs us to, but that doesn't mean the person can never leave their home, and we need to think of their outdoor. I think of their outdoor, especially for transportation, if they have gravel or if they have a real difficult time getting to their transportation. Like a lot of times it's door to door, so they have to be ready, and the transportation company can't come inside and get somebody. So we need to look at the accessible entrances and their ability to navigate where they need to go. This is a picture of an environment, and this is a pretty big curb that I probably wouldn't recommend somebody going up, but this chair is showing how the front kind of caster comes up, and it ends up when that wheel goes over, there's stability on the back wheel, and then that person is up on the grass and they have all 6 points down. The front ones are really considered casters, and this is I'm going to say front wheel, but I feel like this is a sure step, which may be considered a mid wheel. And then you have these drive casters, which are definitely in the back. So just be aware of their environment and make sure you help them understand what their limitations are. This is another picture of an environment. What I like about this is that sometimes a lift is actually a better solution than a ramp. So your ADA requirements is for every inch up, you need to have 12 inches out. So if this is a 4-inch step, and this is a 4-inch step, and this is a 4-inch step, and this is a 4-inch step, so you have 1, 2, 3, 4. I'll have to do my math here. So you have 16 inches, and then you have to have 12 feet out. So you have 192 inches that you have to have a ramp. So that's 16 feet of ramp. And then within the ramps, there's codes that you have to be able to have a turnaround. So when you start thinking of all that lumber and all that space, sometimes a lift will solve the problem for you, and sometimes it's more cost effective. So thinking about how they're going to get in and out, if this is their front door and a ramp is not feasible, there's no portable ramp that's going to help you get up there. Sometimes a lift is a good solution. Transportation. So asking people, how are you transporting it? Most people think the power chairs break down and can get into the trunk, and so don't make any assumptions, and help the individual understand what their options are for transporting. If the individual can be transported in the mobility base, sometimes I will ask like what type of transportation they use, so that if I need to get tie-down systems for them, sometimes tie-down systems are not covered, so I need to work with them so that if they are going to take public transportation, that I know the public transportation will accept them as a ride. You always want, in a vehicle, if a person can transport them or can transfer themselves and sit in the front or sit into the seat of the car, it's always better for the Transportation Safety Act. You know, I know a lot of people that I work with, a lot of the consumers use the bus, And a lot of the consumers have been frustrated because the bus drivers don't tie down their chairs properly, and we've had a lot of damaged chairs. And so I had a guy that he's a para, and he told me he just transfers into the bus seat, and so that he doesn't have to deal with being tied down in his chair. So we talked about, is that a safe option for you? And, talking about what the liabilities are. So what a tie down system is on a manual chair. If I have a picture. Where are my manual chairs? So on a manual chair, I would tie down here, and then I would tie down like on the cross brace. But some manufacturers actually, like on the back, will add a bracket that you can attach a tie down system to. Power chairs. Let's see if there's a picture of one on here. It's an actual, right here is one. It's an actual bracket that is added to the chair. It's a clamp and an access point for a tie down system. Somebody that drives a vehicle will have a automatic system that is built underneath the base of their power chair. So when they drive in, it clamps down and locks. Most of the tie down systems that we have to ask for are going to be added to the chair. So like this chair, this is probably a point for a tie down, and all the manufacturers are very different. But you have to add that on, and a lot of times it's depending on the manufacturer, it might be an upcharge. Steph, did that answer your question? Sorry when I go into my jargon. Okay, let's see. Okay. And looking at how they're going to pull the chair in and out of the vehicle. Functional activities, and so looking at the functional reach, looking at the transfer, if someone's getting their chair, if they have any specific seat to floor height, with the FSHD muscular dystrophy that shows a lot of proximal weakness and a lot of hip flexion weakness. I've had people come and say, I need my seat to floor height to be X amount. My environment is set up for that. And so I need to be aware of that and incorporate it not only into the equipment, but into my documentation. So that has to do with transferring to other surfaces. But I ask for your entire home, do you have any specific considerations of what you need to do, what you can do currently that you need to maintain, and maybe what you can't that we need to consider. Okay, let's go to the test. Told you this wasn't as bad. The first one is heavier. This is mobility. I will launch it. We have 32% submitted. Let's all get it submitted so we can wrap this up. 54, good job. Okay, we're 70%. I'm going to go ahead and close it, review it, and share it. So, clinical indicators for a dependent mobility system to provide support for a very young child. Yes. To provide a means of independent mobility, no, because that's what a dependent, we don't, if someone wants to be independent, we're not going to put them in a dependent unit. To provide one-handed access. So if they only have one-handed access, we should be able to do like a one-arm drive or some type of mobility or power so that they wouldn't be dependent. And to improve transfers. So transfers would probably not be a reason to do a dependent system. The best answer here is to provide support for a very young child. If anyone has questions about why we did so poor as a group on this one, shout it out or type it to me. I'm going to go on to the next one. Which of the following needs to be evaluated before recommending a mobility? Home, transportation, transfers, all the above. That was easy. Proportionate control provides the following directional. So 360 is the correct answer, and that was on the slide. So it does do 4 direction, it does do 8, but it's not limited to just 4 and 8. It does do 180. So these aren't wrong. It's not that they don't do that, but 360 is the best answer because it provides that 360. And I guess I'm going to pause back. 4 direction would be non-proportionate. So 4 and 8 would be a non-proportionate, and that would be the electronic one. So proportionate is 360. You know what, Stephanie? I guess when I was reading that, a clinical indicator, I do agree with you. I'm not sure if that's the best written question because a young child isn't a clinical indicator. I would want something to be like a clinical indicator. Maybe you can test me on this. No, a child with a child with cerebral palsy that doesn't understand cause and effect. So they would need a dependent mobility system. I do see how that was poorly written. So thanks for shouting. Sometimes we look at them so much that it's hard to look at it clearly. And I think we need to shake up some of these questions too. So when we talked in the very beginning, I think that some of these questions are the ones that are on that end of module test. And so I saw that they were in my handout. And so it looks like we're keeping some of the questions in the handouts. So that end of the module test is not well, you didn't pass, so you don't get the CEUs. It's more of a helping you prepare to study more. And so if you're somebody that doesn't do mobility and some of these questions were really throwing you off, you may want to go back and study some of these concepts more. I'm a seating and mobility person, so I have to spend time with like Heather's lectures and some of the access points to understand the processors and hard technology, soft technology. So use these as a guideline for your comfort of how you understand the information. Okay, so it is 9:29. You guys are hanging in there. We've had Halloween, we've had daylight savings time. I don't know if you guys are as tired as me, but thank you for hanging in there. We finished 1, 2, 3, 4, 5 sections. We only have 3 more to go. You get a break from me, and so you'll have Heather on Thursday. I will be here, but Heather will be leading the show with AAC and computer access. So we are finished for the evening. We will stay on for a few minutes for any questions, but everybody have a great evening.
Therese, I believe the CEU credits don't come until the very end. So the very last test that you will get emailed to you that you take will then generate those CEU credits. So Thursday night's quiz will not be an issue in order for you to get those.
Yeah, and you can review it. You can listen to the audio for the content. So I was looking down. My son's college soccer team is in semi-playoff tonight, and they won. So they go on and play Thursday.
Oh no.
I know. I'm like, the universe doesn't like me right now.
Man.
It's okay. Maybe it's good luck that I wasn't there. I don't think they have any more questions.
Oh,
Sometimes I wonder if people stay on just to see if there's any questions.
Yeah, there's Michael has one.
Michael, I can't find the hours. I'm sorry, I've asked this before. I can't find the hours where to get the form. You mean your verification of work?
Yeah, I think that's what I mean. Yeah, I think you have to call to get those forms emailed to you. If I'm remembering correctly. Yeah, okay. Yeah, if I'm remembering correctly. So if you just go to the I think it's the certification section in Resna. There's an email address.
Okay. I think we're good to sign off. I'm going to stop recording.
All right, sounds good.